Okay, well, thank you for joining us today to look at LOCCATE, which is a clinical tool to analyse and compare results from formal assessment. Helen and I will be talking today. We've got over 30 years experience each in PDOC, and we also, during that time, invented and developed the SMART assessment, which some of you might use or be aware of. Helen works at the Royal Hospital of Neuro-disability as a SMART consultant part-time, and we also both run Gill-Thwaites and Elliott Consultants, which is where we assess patients in disorders of consciousness. So today, please would you pose any questions that you have for us in question and answer tab on your screen. Because it's a webinar and there are quite a lot of people, it's quite difficult to do sort of live questions. So Jess will collate those and then we'll look at them at the last 15 minutes of the session, and we'll have a bit of a question and answer and any discussion required. We structured the talk so that we begin with looking at the background of LOCCATE and why we developed it. And then Helen will look at the clinical application of LOCCATE and how you would actually use it in clinical practice. So just a couple of points on current prolonged disorders of consciousness, just to set a bit of a scene. Prolonged disorders of consciousness is defined as a term used for an individual in a disorder of consciousness that lasts for more than 4 weeks. It's an umbrella term for the diagnosis within disorders of consciousness. So that now includes coma, vegetative state, minimally conscious state, and emergence from minimally conscious state. The spectrum of disorder of consciousness within our understanding has really developed over the years. More recently, the most recent development has been the division between minimally conscious minus and plus within the diagnosis of minimally conscious state. And that was first researched by Bruno et al. In 2011. And it wasn't until the RCP guidelines for disorders of consciousness in 2020 that in the UK we've used that as a partial diagnosis. The other differences are that in the USA and the European guidelines are quite different from the UK guidelines. And we're basing our talk today around the UK provision. And it is different because of the way that our health system is set up, how we see our PDOC patients through different pathways, and also our legal system and framework is quite different, and the guidelines need to reflect that. So the framework differences for sort of legal requirements in 2017 also changed, where there was a case with Briggs where it was decided that there was no longer the need for a diagnosis in order to withdraw nutrition and hydration. Prior to that case, if you were in vegetative states, then the application to the Court of Protection would perhaps be to withdraw nutrition and hydration. But the Briggs case said it didn't matter whether it's a diagnosis of VS or MCS. And that was significant in the changes for our guidelines. And that brought about a change in the BM guidelines in withdrawal of nutrition and hydration and the RCP guidelines. And the reason why I've highlighted this today is that these changes have then put an onus on the clinical team and best interest meetings to really look at what is the right pathway for your particular patient. And it's about not now about the diagnosis, but it's about quality of life. And the assessments and the way that we handle assessments and look at them, it's about identifying what's happening for the patient so that we can make those decisions in best interest meetings. So just to remind everybody, there was a recent paper by Derek Wade and Lynn Turner Stokes et al. 2022, which was really looking at some of the criticisms about the UK RCP guidelines. And they were reiterating why the assessment is particularly specific to the UK and why we've actually got the guidelines that we have. And in those guidelines, we have 3 validated tools: COMA recovery scale, the WHIM, and the SMART assessment. So those are the standardized assessments that are recommended by the RCP guidelines. And various places use different assessments, and various teams use different types of assessment and different combinations of assessment. And one of the things that the RCP guidelines identified was that combination of assessments is a good way to really understand all of the responses and abilities of your patient. But when you have combination assessments, they are not necessarily compatible in the way that you can compare them. And so that was part of the reason why we started to develop the LOCCATE tool. So if we just have a look at, as clinicians, what is it that we want to know about our PDOC assessments? It helps us to start to identify what we need to document and how we can compare the different standardized assessments that we have. So one thing, obviously, is what are the highest responses that the patient has and to what stimulus? So that's helping us to identify our evidence for the goals that we are going to set clinically. And it helps us to understand what abilities that patient has, if they have abilities within their condition. It's also useful to know whether responses are motor or communicative. And that's because it can help us to identify the modalities that we have that are strong for that patient and the responses that are relevant for that individual, and helps us to formulate specific therapeutic approaches. So understanding where those modalities of strength are useful. Our assessments also need to show us whether responses are reproducible. So that means that they can occur at least twice or more before we can verify and say that they're responses that that person has. And also whether they're durable. And this is more important when we're looking at emergence, but it's about whether there is durability in those responses. Can that individual with a PDOC, probably at the higher end of minimally conscious state, maintain those higher level responses? And that helps us particularly when we're assessing for emergence. And further information on sort of reproducibility and durability is outlined in the RCP guidelines. So reproducibility and durability helps us to identify a diagnosis, but it also helps us to place that person on the spectrum of PDOC. With our assessments, I think it's also important to know which assessments provide which responses, because then we can find out if it's the technique, if it's the stimulus, if it's the assessor that's been able to find that, if it's a certain facilitation that's been able to find the responses. And that helps us to identify what assessments might be appropriate, or combination of assessments might be appropriate moving forward, and also where responses are found so that they can be investigated and explored, particularly if there are differences between assessments. The other thing that's important, and certainly was highlighted in the RCP guidelines this time round in 2020, was that really clinically we should be looking at the trajectory of patients. So what's happening with them over time? And that's be able to identify change, and whether the person's increasing in their responses, whether there's decrease or whether they're plateauing. Particularly important when you're looking at allocation of resources, whether there should be further rehabilitation, for example, or whether you're starting to look at, is this a situation where treatment is futile, or where treatment is perhaps not indicated or in person's best interest, and can also inform withdrawal of nutrition and hydration. So the trajectory is important to be able to see and identify. And in some current practices, it's quite difficult to see what's happened over time with somebody, particularly if they've moved between units. So the RCP have recommended the 3 standardised assessment and identified that clinical evaluation by experts in assessing patients should be through serial assessment and monitoring over time. So in the development of LOCCATE, we were thinking that you need a tool in order to look at what's happening over time and not to just use scores as they've, this is the score that they've got in an assessment, but what does that mean in terms of responses? What does that mean in terms of their change over time? And how are we monitoring that to be able to have evidence to make decisions that we do about patients? So our assessments need to provide a clear picture of the patient, provide clinical evidence for our baseline for intervention, for our diagnosis, for identification of measurable changes, and also that trajectory, which I keep coming back to. That's very much part of what we're trying to look at and explore as we work with a patient in PDOC, which is quite often for weeks and months, if not years. And again, the durability of responses. So being able to identify that and understand it is important. So we're going to talk about LOCCATE, and LOCCATE stands for the levels of consciousness, calibration of assessment and tools evaluation. So why did we develop it for PDOC? The fact that a PDOC patient is seen by different units, different assessors, different assessment tools over a period of time is quite challenging for us to understand the trajectory of change and understanding the responses that a patient has and how we deal with those over time. It's also hard about identifying, less about diagnosis, but more about where they are on the spectrum. What are the small changes that may occur within a diagnosis that are significant, as well as the changes that occur between diagnosis. So clinically, we're not always looking at increasing somebody's ability to get a higher diagnosis on the spectrum. It's about what can they do, and can they do more? Can they do it more frequently or at a higher level? So we're looking for a tool that can help us identify that and guide us clinically. Also, to be able to discriminate between different tools. So we are using different tools, and that's really valid. It's important to use the most appropriate tool for the patient, the assessment tool, but also for the environment where they're being assessed. And it's appropriate sometimes to use combinations. So how do we use this information, and how do we compare what we've seen and use them as tools to guide us in what we're doing? We also want to identify levels and frequency of responses and have that so that we can see changes and we can see things that are altering and things that are staying the same. And so LOCCATE is going to provide that. And also we were thinking of the tool being able to support these best interest decisions. So for having evidence to make decisions about what we're going to do in terms of resources, informing families about changes in intervention perhaps, and using a tool that we can clearly see what's happening with the patient is useful to discuss with the families. It's also helpful in terms of research when we're looking at patients and patient changes and what's found within different tools, and also for audit purposes, and Helen will talk about that a little bit later. So the overview of the tool, it is a calibration tool. It's not a standardised assessment. It is a tool for documenting what you've seen in other standardised assessments so that you have it on one clear document. It provides set criteria to compare and gives you documented evidence from each assessment. So it's like a summary, but it's like a summary that then gives you information for your interventions and for your decision-making with your patient. It helps you to define the levels of consciousness and categorise the responses into motor and functional communication so that you can really target intervention and target approaches. It helps you to look at where that person is on the diagnostic spectrum. And within that, we're looking at COMA, VS, minimally conscious minus, minimally conscious plus, minimally conscious emergence. So it's allowing that person to sort of be documented as they move through and having the information so that we can see as they move through this real spectrum of disorders. What we've also done with LOCCATE is subdivide some of the diagnoses into lower, mid and upper. And that's really clinically so that we can see those small changes, which we might not see completely if we're just looking at a diagnostic tool. So it helps us to see where they are within vegetative state or where they are within miliary conscious state, and then make some choices about change and decisions. And it helps us with that thing that I keep coming back to, which is about the frequency, the reliability, and the durability. So it helps us to really be able to see that when we've got all of the assessments together, and we can start to compare the things that we know about this patient. So Helen's now going to talk about the LOCCATE process.
Thank you very much, Karen. Yes, so that leads us into the LOCCATE process, which has basically got 4 stages. The first stage is the criterion scoring and the associated inferred diagnosis. And we call it inferred diagnosis because we're talking about a diagnosis based on the LOCCATE and obviously the assessment tools. And obviously any diagnosis requires confirmation by the lead expert consultant, who obviously takes into account all of the information that they've gathered. The next slide, please, Karen. So the criterion scoring is the first stage, and the inferred diagnosis. So as you can see from the table, starting from the bottom, you have the COMA patient. So you can apply this to the Glasgow COMA scale, and we'll give you some examples of that later on. So we have the lower, mid and upper of COMA. So you have levels 1, 2, 3 for COMA. Those same levels apply for VS, but obviously you have eyes open and all the criteria that link with VS. So we have lower, mid and upper there. So they're levels 1 to 3 for both of those, dependent on the eyes open. LOCCATE criterion level 4 will apply to MCS minus. And then, as Karen said, we have divided MCS plus up into lower, mid and upper. So that includes 5, 6 and 7. And again, I'll give you some examples of this in a while with the other assessments that we're talking about. And then LOCCATE 8 is emergence, signs of emergence. So that's the spectrum, and that's the criterion scoring. So you have from 1 to 8. Okay, next slide. So let's talk a bit about the COMA and VS. So again, it depends if the patient's eyes are open or closed. So we'll start at the bottom and we'll have a look at the level 1. And you can see across the board that we have no responses. So let's say VS patient does no motor responses and does no functional communicative responses, and the same with someone in COMA. That would be at that level. Then for level 2 is what we're calling the mid level for COMA and VS. That will be those reflexive responses in the motor that we've seen with all our patients. And certainly for the functional communication, it's reflexive, non-meaningful facial expressions. So they're not contingent to any stimuli. They have no meaning, and they would go for the functional communication level 2. Level 3, slightly higher level, but a little bit more refined, but still not showing awareness or arousal if it's the COMA patient. So for motor, you'd have just a withdrawal response or those non-meaningful spontaneous movements. So they're slightly different to those reflexive responses, aren't they, at level 2, but they are still in the category of VS or COMA, depending on the patient's levels. And then for functional communication, you might have those non-meaningful facial expressions, vocalizations, but they could be to stimulus. So they're not just happening all the time, which would happen at the level 2, but they are specifically to stimulus, but they have no meaning. So again, it's just doing these slight subdivisions between these areas. So when you're reporting it back, you can actually start to see if there's been any subtle changes in the patient's responsiveness. And again, I'll give you some examples later in a case study. So that's your VS and COMA. So then we're going to look at LOCCATE criterion for MCS minus. And obviously this is clearly defined in the RCP guidelines. So when we look at the motor function there, so like we're going to explore that, and the functional motor movement. So you've got your localization, let's say hand towards let's say tactile stimulus, or you've got visual fixation or visual pursuit. And also those spontaneous, meaningful movements, such as brushing hair out of eyes. This is obviously a repetitive movement, and we've all seen that with our clients. And then certainly moving on for more functional communication, you've got active movement there within guided activity felt with facilitation. So you know there's some purposefulness about the movement when you're, say, guiding a hand towards brushing hair, but they can't complete that task at all on their own. They can't initiate the task. And you might have those patients who manipulate form. If you, let's say, for example, put a ball into their hands, they'll hold it and manipulate it, but they don't know how to use it. And that's all in the RCP guidelines. And then your functional communication is obviously those communicative facial expressions or meaningful vocalizations that are in context and or to specific stimuli. So you know, for example, they're smiling to voice on the left, for example. You will certainly get to know whether that's meaningful after time with your patient. And then you might get those intelligible verbalizations. They lack meaning and they're not in context. They would fit in your criteria for MCS minus. Thanks, Karen. So now looking up at these higher levels, so LOCCATE level 5 to 7, like I say, they apply to lower, mid and upper. So let's have a look carefully at the motor function first, so we can see the sort of complexity of these motor function movements changing. So if we start off at the bottom of this slide in the lower, so these are going to be sort of responses that are appropriately directed to the type of stimulus. They're interacting with this stimulus, but they're not responding to verbal or written instructions or even cues that you might be giving them. So for example, you might have a cause and effect, you know, able to sort of press a switch or use an iPad, but that's just moving towards touching. They're not following your instruction, they're just doing the activity. And then for functional motor, they could complete a simple task without instruction. We've seen it again, haven't we? Where the patient might remove their socks, adjust a hat, you put glasses there, take the glasses off, but they're not doing it if you ask them to. So they're picking up from the cue of the item. So level 6 for motor would be a higher level, and that's mid. So this is where they are following your instruction or the cue, for example, or they're able to discriminate. So following a command, say move your thumb, for example, they can do that. And then the higher level would be those responses at, for emergence, but they're not meeting the criteria. So the motor ones would be choice making, matching, that type of thing, which is all again in the RCP guidelines, or that they can use an object, a pen, for example, but again doesn't meet the criteria. Okay, so you can see the levels within that. And then if we start at the bottom again, look at functional communication, how do we subdivide that? Because it is such a big area, isn't it, MCS plus? When people say, oh, the patient's MCS plus, they're not MCS minus, it could be a large range of motor and functional communicative responses. And we need to start to say, well, what exactly is this patient doing? So MCS plus lower for communication, we'd look at someone who can copy facial expression, gesture, for example, uses automatic speech to finish phrases, or verbally responds appropriately to stimulus. For example, they might say, go away in response to having an injection. But again, they're not following these verbal instructions. If you ask them to do that, they can't do it. And obviously, this is a very complex area. So, you know, there's some responses that might fit in between, but these are the general areas if you look at the sort of clue on the left-hand side. So these MCS plus mid for communication would be that they demonstrate yes and or a no, but they can't functionally ask the question. So we often see it, don't we, say, for example, using a switch, show us yes, they press it once, show us no, they press it twice. They can do that, show me a yes, they might put a thumb up, show me a no, they do another gesture. But if you start to ask questions, they're not able to do that. And then this upper level, again, is going back to the motor criteria as well. So it's those patients that show evidence of those criteria for emergence, but they're not meeting the RCP guidelines. So for example, uses gesture or other methods to make their needs known. They can make choices to indicate yes, no, answers questions, situational and autobiographical, but don't meet the guidelines, which are very clear on the frequency and the durability of those responses. So that is breaking down where you'd fit those patients in the MCS plus category. And you can start to see how that will help at least to start to say if there's been any change in those patients, if they've moved from, for example, a cause and effect response, and now they've started to follow instructions, shows a subtle difference, which needs to be catalogued for your clinical guidelines and feedback, not only to the team, but to the family as well. It's clear and it's telling them what the patient is actually doing and not just giving a global diagnosis. Families, teams need to know what's happening. Thanks, Karen. And then the emergence category for LOCCATE 8 is very clear. So that's those patients that meet those criteria, and the criteria clearly spelled out in the RCP guidelines. So you can see there what that would be, but it's basically very clearly spelled out, but meeting the frequency is defined in the guidelines. Okay, thanks. Okay, so next we want to look at this issue about reproducibility, and as Karen talked about that for us earlier. So we're now looking at ranking that reproducibility. Let's move on. Okay, so what we are recommending is that when you're looking at LOCCATE, you have to sort of think about doing, at least, well, the CRS, for example, recommends 6 assessments conducted. So you might do 6 to 10, for example. You would look at a range of WHIM assessments. Don't use just one. You have to sort of do a series together to be able to collate your information. And as you know, SMART relies on 10 assessments over a 3-week period. Stop, and then you work out your intervention. So you do need to do at least 6 or more assessments to be able to come up with something useful on the reproducibility. So we've put codes to these. So for example, if you did a series of, let's say, 6 WHIMs, you want to see, did that response happen 2 or more times to get level A? So it would be 2 to 4. So in other words, when you did the WHIM, you got them to visually track, and they did it 3 times out of, let's say, 10. Then you would put them in, they've done it, but it's been seldom but reproducible. They've done it more than once, but they haven't done it 10 times. So that would go there. 2 to 4 would be A. B means they've done it often. So for example, you've done the assessment, but they're tracking in 5 sessions, but not consecutively. Okay, so that would be showing they've done it often, but not always. And then C would be more consistent. So they're doing it always. So in other words, they do at least 5 sessions in a row, because here you're starting to pull out, aren't you, the fact that they can reproduce it. A lot of people talk about PDOC and they talk a lot about, oh, it's not consistent. Well, actually, consistency isn't relevant, really. What is relevant is it reproducible, and how often is it reproducible? So this will give you much clearer, saying, well, they've done it 7 out of the 10 times, for example, and they've been in a row. So this is where you can start to pull out if there's been a change. So let's say, for example, to certain stimulus, they were tracking twice, but when you brought in something more familiar, they start to do it always, or more, 5 times in a row at least. That's showing there's a change, isn't it? And that's those subtle changes you really need to pull out. Thanks, Karen. Okay, so we talked about the criteria, we talked about the ranking, the reproducibility. So now we can allocate a calibration score. So as you can see here, obviously on the left, you've got the LOCCATE inferred diagnosis, the spectrum we've talked about. And then as you can see, we start at the bottom, we've got COMA 1, and then you've got mid is obviously 2A, B, C, and so on up to 7C and then 8. So we're talking about the criterion and the reproducibility of that highest response. And that will then give you a nice LOCCATE score. So you can start from 1, moving up to 27. And those subtle changes you'll be able to measure using graphs. We've got a graph that you can use, or graphs, or you can document it on the report form. So you can actually show change on this LOCCATE score. Okay, Karen, thanks. So the final part is generating a LOCCATE criterion and value. So what we want to know is how have they changed and where have they changed? So let's give some examples. So this is the LOCCATE summary form. And you can see, right, number was the first one. The first assessment we want to analyse is the Glasgow COMA scale. How many assessments did we do? Well, they had 3, not as many as we'd like, but that's that. Their initials, the date. And what was the assessment score from that? Glasgow COMA scale 3, and it was COMA. So then what we've talked about, haven't we? We've talked about the motor and functional communication aspect of it. We want to know, what does that 3 mean in terms of the LOCCATE? So what this patient was doing, they had no motor responses or eye opening 3 times. So that's obviously at that lower level, isn't it? So that is COMA 1, lower, and the score on the right-hand side would be 1 on the calibration score. And there's no functional communicative responses. That's 1 lower. So if they're not responding, you can't do reproducibility for it. So you've got 1, 1 is your calibration score and value, and your overall score, the highest they got from that is 1 because it's the same. Okay, so that's how you do that. So let's give you a case study to help you through that. We have someone who started off with these Glasgow COMA scales, and you can see that first row is shown there. Then they had another Glasgow COMA scale. They had a series of 4. You can see in that row too. So their score was 8 on the Glasgow COMA scale. They showed in the motor abnormal reflexes. So that's no response now, is it? It's not no response, it's reflexive response. So that goes up to 2. It's only happened 3 times. So the score for that is 2 in terms of calibration score. And then underneath the functional communication, they were doing incomprehensible sounds. That's 1 level up. They've only done it twice, that's 2A. So you've got 2 over 2 there, and the highest is 2. So they've already moved from level 1 to 2. Okay, so they're still in coma, but they've moved up. So then after that, the patient's obviously moved on from coma, and they've had a CRS, and that's that 3rd row. They had 6 assessments, and that came out as VS. So in the motor responses, you can see that they had flexor withdrawal, which is level 3. Those with withdrawal responses are level 3. And they had it only 4 times out of the 6. So that's the lower level A, and that's a score of 12. And then when you look at the functional communication, there was no responses observed. So that would be 1. VS lower, and that's 8. So you can see that would be a ratio of 12 over 8. So you'll be able to always see, have they changed in the motor and have they changed in the communication? So the answer to that on this example is yes, they've changed in both, but the motor responses are showing those slightly higher levels on the calibration score, and that highest score is 12. Still in vegetative state, having moved from coma. Thanks, Karen. So then we're moving on. So we've done a SMART and a WHIM with the same patient. So with the SMART, well, obviously we've done 10. And we're starting to see that in the motor, this patient's now following instructions. And what you have to be on these, on the form is very clear about what instructions are they following. So this one is moving hand, moving head, and lifting thumb. And the patient's been seen to do that 5 times. It's 6B, and that will be because it's not 5 in a row. So it's doing it sometimes, but not always. Okay, so that would come up as 22 on the calibration score. And then facial expression, smiling and crying, it's obviously meaningful, and that would be 4A. So only doing it 4 times. So that's 22 over 15, high score is 22. So that's showing MCS plus at the mid-range. So it's certainly moving up on the trajectory. So then we look at the WHIM, which was obviously conducted at exactly the same time. It tells you what the WHIM score was. And on this WHIM, the team found that they were following instruction to move the head 3 times. And that was only happening 3 times compared to the SMART 5 times. But let's have a look at that in a minute. That will be 6A, because it's the same level, but it's not as often, 21. So slightly below that SMART score there. And then they're also showing that the patient smiles to the family, and that is quite often. So it's 9 times in those 10 sessions. So we have here more consistency here, don't we? So that's 4C13, actually. Yeah. That's, sorry, there's a slight error there, but it's more frequent than this. There's a slight error in that scoring, but don't worry. Well, what this is showing us, isn't it, that when we're talking about what is this locate going to help us do, it tells us that he's definitely moving better to move your hand, move your head, lift your thumb, than they do in the WHIM, move your head. So actually, maybe the team need to think, well, let's give them these other instructions. They might be better. But what we're also finding out on WHIM is that he's smiling more frequently when the family are involved. So we definitely need to think about that and involvement of the family to try and elicit those positive responses. Okay, thanks, Karen. So what does SMART tell you? You can see here, as Karen was saying, you can see the progression. If you put all those on a bar chart, you could see the progression over time, and that was obviously a trajectory going up. But you might see, for example, there's a dip in that trajectory over time, and you might be able to wonder why that is, and we'll talk about that in a minute. And then you can also look at variance. So, for example, different assessments will give you different scores, because you're saying in each assessment, what exactly were they doing and what to, and what is it in those assessments that we can tease out. So what will it tell us? It will tell us the issues about variance on external factors. For example, has their medical status changed? They've had a chest infection, the scores are going down. Is it positioning, that what they do, let's say the WHIM when he's in the chair, and the CRS when he's lying in bed, and actually he responds better during positioning in the chair. You might find as well that the assessor's skills, you can look at that. For example, the assessor doing the WHIM might be particularly good with facilitation hands-on. It's the physio, for example, and they've managed to get a meaningful, purposeful movement with a pen, for example, and what facilitation skills. And then you might be looking at the assessment tool. For example, well, they've managed to use the switch, for example, which is in the SMART, or they were able to, let's say, for example, respond better to different types of stimuli. What is that stimuli and what response is it getting? And then you can all sort of start to ask yourself questions like, what is it that we need to use that's come out of that assessment to change? Who needs to do the assessment? Who needs to do the intervention? What stimuli should we use? Is it better if we use familiar, for example? So it will really focus your intervention and management. So just as a finishing off here, so LOCCATE, we use it as an audit tool. We use 35 cases to explore the results. 22 were male, 13 female, and you can see 17 traumatic brain injury, 11 anoxic, and 7 have medical conditions. And it was conducted between September 2010 and October 2019. And they'd all had SMART assessments. Of the 35, 26 demonstrated awareness of their self and environment. So we obviously didn't have any COMA patients on the study. 26% were vegetative state. 71%, that's 25, were MCS, and 10 of these were MCS minus, and 1 emerged. We found, having done this audit of our SMART, that all signs of awareness were seen in the motor modality except for 2 patients. That was 1 who was MCS minus and 1 was emergent. But by being able to divide up motor and communication, we could really explore those areas. So that's where LOCCATE is useful when you're sort of analysing the types of responses you're getting. Of the we found that 20 out of 35, that's 57% demonstrated facial expression. So it is really important to pick those up and asking yourself as experienced assessors, is it contingent, is it meaningful? And that's why it's really important that whatever assessment you use, you are trying to use the same assessor over time if you can, because they'll build up a picture. You're like a detective. You're trying to say, oh, I've seen that. Has it happened again if I try different stimuli? So you really need to layer up that evidence. And interestingly enough, olfactory and gustatory, obviously very careful to, especially with SMART, we'll always work with the SLT to decide if it's appropriate to use it. They're the prime indicators of awareness for functional communications. They were the ones who actually pulled out those facial expressions in terms of starting to see if there's any meaningfulness. And interestingly enough, 63% did not demonstrate any visual functional ability. So with this locate, you will be able to see where is that highest response coming, what modality. And that reflects the work done by Keith Andrews et al. At RHN, which showed similar levels of issues with functional ability. So the audit did show us that there's a need for inclusion of a wide spectrum of stimuli. And I think we're saying that when we say use a whole range of assessments, because we need to see what is it they're responding to and how do we focus in on that. And then finally, the switch that we use in SMART was able to achieve yes/no response from 9% of those patients. So that's a useful.
Okay, so just bringing it together, we sort of tried to identify that PDOC assessment is about identifying the most appropriate assessment, and it's often a combination, and it does depend on what level your patient's at and what environment you're in. So it's about using a standardized assessment, but also using them in combination so that we can then compare them and look at what we have. So LOCCATE, hopefully you can see that offers a process for documenting and comparing assessments and helps you to evaluate what current assessments are finding, and then serially what we're finding over time. So that helps you with the reproducibility, the durability of current assessments, and then looking over time what's happening in terms of the trajectory of change. We're hoping that people can use LOCCATE to sort of focus as a multidisciplinary team, or bringing your assessments that you've done to really look at what you found and what are the stronger elements for the patient, so that you can find out the abilities that they have, the environments that they have that in, the facilitation that's needed, and also with the family, looking at, are there aspects where the family are finding more things, perhaps, or to discuss with the family, to show them those minor changes, whether that's increasing or decreasing, or whether they're plateauing. It's just to be able to show a tool that can show that. There's also been talk in the development of the PDOC guidelines about the future having a PDOC database. And so the documentation and being able to look at what's happening with individual patients is a really useful tool to try and understand, how we might use that information for the next patient. So it could be a sort of learning tool as well, and hopefully feed into databases in the future. So just before we go to questions, we've got up here, there is a paper on LOCCATE in the Neurophysiological Rehabilitation Journal, and that's the reference for it. LOCCATE is also, as the tool with the manual and the forms that Helen's been going through today, are on the RHN website. Briefly, so you could get them today to download, but they're long-term, they're on the Gill-Thwaites and Elliott Consultants website. So in the future, if you want to look it up, have a look on that website. We've got, in relation to this, we've also got a couple of courses that are coming up at the RHN that people might be interested. One is the SMART course, and that's running in September. It runs over 5 days and it's divided over a 2-week period, and it's via Zoom. And there's also a new course that we're running on PDOC intervention, and that's really focusing on the information that we've been talking about today, what you get from your assessment, and then what do you do with it. So how does that evidence guide your intervention, practice, goal setting, and how do you look at those incremental changes? And we will be using LOCCATE as an example as to how you might document that, but also talk about how other people use their assessments in practice. It's a very sort of interactive course, and really focusing for people that are working in PDOC, and we'll be using your own case examples as well. And that's on the 13th of October. Jess has kindly put a link to the courses in the chat, and you can also Google on the RHN website.